This talk was done for a meeting in 2023. The anatomic distribution of sensory innervation around the joint remains largely unknown. I have spent 5 years trying to better understand it, and I'm going to attempt to explain what I learned about the anatomic distribution of sensory innervation around the elbow, the shoulder, and the hip joint. We have really started to work this project in 2020 when we published a literature review that summarized all described articular branches innervating the elbow joint. And 5 nerves were found to provide articular branches to the anterior and posterior capsules of the elbow. We found that innervation of the elbow joint involved the median radial, musculocutaneous, and ulnar nerves from muscles surrounding the elbow, as well as the medial antebrachial cutaneous nerve. The radial nerve was found to be the greatest contributor to overall elbow innervation, because it provided sensory innervation to both the lateral and medial capsule. However, innervation of the medial anterior and posterior capsules was found to be quite complex. Although the ulnar nerve is the most frequent contributor to capsule innervation, participation of the radial median, musculocutaneous, and MABC nerves has also been reported. The anterior capsule was found to be primarily innervated by a plexus of muscular branches of the ulnar, musculocutaneous, median, and radial nerves. A higher density of nociceptors was identified within the posterior capsule. Mechanoreceptors were also found primarily in the anterior capsule, as well as the medial annular and lateral ligaments. These latters participate in the dynamic stabilization via the musculoligamentous's protective reflex, and we hypothesized that the origin of articular branches, muscular or mixed, may also be a reflection of their distinct roles in proprioceptive stabilization and pain generation about the elbow joint, and the resulting frequency map of articular branches and sensory receptors of the capsula ligamentosa structures of the elbow provided an anatomical basis with which to propose targeted denervation. We postulated that thorough denervation of the posterior capsule, in addition to nociceptive branches to the anterior capsule, might be sufficient to reduce or eliminate pain originating from intra-articular pathology. Furthermore, this technique could maintain the integrity of mechanoreceptors primarily located in the anterior capsule, which could play a crucial role in avoiding accelerated arthropathy and recurrent elbow instability. And 1 year later, in 2021, we published a cadaveric study to describe the total selective denervation of the elbow via 2 anteriorly based approaches. We assumed that denervation techniques should focus on the posterior capsule, but also include nociceptive fibers supplying the anterior capsule. The study confirmed it was feasible to cut the articular branches of posterior cutaneous nerve of the forearm and of the musculocutaneous radial, ulnar, collateral, ulnar, and MABC nerves when carrying out this procedure. We also confirmed that a nociceptive denervation of the elbow via 2 approaches was feasible. Denervation of the elbow joint could be an attractive alternative total elbow arthroplasty for young patients with advanced osteoarthritis. However, additional studies are still needed to determine the safety and effectiveness of this method in terms of pain relief. But during the same time, we also work on the sensory innervation of the shoulder joint. In fact, we started by the shoulder, because between 2016 and 2019, we published 9 papers about the new anatomy of the suprascapular nerve and its anatomic contribution. And in our new description, the distal suprascapular nerve contributed 3 distinct sensory branches to the subacromial bursa, coracoclavicular, and acromioclavicular ligaments, and PGH capsule. This study has elucidated previously undescribed anatomy of the distal suprascapular nerve and its 3 distinct articular branch courses, medial and lateral subacromial branches, and a posterior glenohumeral branch. The description of a bipolar innervation of the subacromial bursa was consistent with the bipolar distribution of the nociceptors in the medial and lateral parts of the subacromial bursa, described in the paper published by Ito in the JSS in 1996. The distal suprascapular nerve provides 70% of the sensory innervation to the shoulder. However, a thorough understanding of the sensory innervation of the shoulder joint required establishing consensus with respect to the anatomic features of all the articular branches innervating the shoulder joint and the distribution of sensory receptors about its capsule and bursae. And we published in 2020 a literature review that summarized all described articular branches innervating the shoulder joint. The innervation of the shoulder joint was provided by the suprascapular, the axillar, the lateral pectoral, and the lower subscapular nerves, which is in accordance with the Hilton's law, and we also confirmed that the suprascapular nerve was the greatest contributor to overall shoulder innervation. It was found to provide sensory innervation to the posterior glenohumeral capsule, subacromial, bursa, coracoacromial, and acromioclavicular ligaments. The axillar nerve was also found to innervate smaller areas involving the inferior portion of the anterior and posterior glenohumeral capsule. The innervation pattern of the anterior shoulder joint was found to be quite a bit more complex, while the medial portion was found to be primarily innervated by muscular branches of lateral pectoral nerve. The lateral aspect of the capsule was supplied by articular branches, arising directly from the axillary nerve. The lateral pectoral nerve also innervated the anterosuperior quadrant of the shoulder, including the anterior edge of the subacromial bursa, the coracoacromial ligaments, and the glenohumeral capsule. Nociceptors were primarily identified in the superior quadrant of the shoulder, including the subacromial bursa, the glenohumeral, the coracoacromial, and the coracoclavicular ligaments, and the proximal portion of the long head of the biceps tendon. The subacromial bursa was the area of densest tripolar nociceptive innervation. These three nociceptive poles may correspond to the location of the lateral and medial subacromial branches of the suprascapular nerve, and to the articular branches of the lateral pectoral nerve. Furthermore, a fine articular branch from the axillar nerve may also participate to the innervation lateral pole of the subacromial bursa. Data summarized in this study suggested that these pain generators were innervated by the same nerves that innervated anatomic regions at particularly high risk of injury. It concerned the suprascapular nerve, the lateral pectoral nerve, and the axillary nerve. In a paper published in 2000, Hirasawa and his team demonstrated an increasing density of nociceptors in the subacromial bursa and coracoacromial ligaments in patients with rotator cuff injuries. Based on their findings, as well as this reviewed literature, we introduced the concept of common innervation pattern, and we proposed the existence of a nerve bridge principle. We posited that these nerves could transmit stimulation from the injured trigger areas to areas rich in nociceptors there, by creating secondary pain sites away from the primary injured structure. This nerve connectivity between pain generator areas and areas rich in nociceptor led us to believe that breaking the three nerve bridges may be a solution to treat persistently painful shoulder. The pain generators and their parent nerves should be the target of treatment, as well as the injured trigger areas, and a selective denervation focused on the nociceptive branches, arising from the suprascapular nerve, the lateral pectoral nerve, and the axillar nerve, could neutralize the pain generator area. And in 2021, we finally worked on the sensory innervation of the hip joint, and we wanted to show that the neuroanatomic distribution of sensory receptors supplying the hip joint could play a key role in referred pain secondary to hip pathology. Thus, we summarized the literature in an effort to establish consensus with respect to the distribution of sensory receptors in the capsule of the hip joint and the anatomic features of the articular branches innervating the joint. Innervation of the hip joint capsule consistently involved three nerves: the femoral nerve and obturator nerve, which supply the anterior capsule, and the nerve to the quadratus femoris, which supplies the posterior capsule, and four accessory nerves: the superior gluteal nerve, the accessory obturator, and the sciatic nerve, inconsistently supplied the posterior or anterior capsules. The pattern of this accessory articular innervation demonstrated redundancy with territories innervated by the three primary parent nerves. We found that the area of densest nociceptive innervation was in fact the superior portion of the anterior capsule. Furthermore, the postero-superior labrum rich in nociceptors was also innervated by an articular branch of the superior gluteal nerve. Conversely, we found that the posterior capsule had relatively poor nociceptor density. Despite its having a lower nociceptor density, we did find that the posterior capsule was consistently innervated by the nerve to the quadratus femoris. We therefore posited that these two nerves contributed to posterior or buttock pain referred from the hip pain, and thus the anterior capsule, primarily supplied by the femoral and obturator nerves, and the superior labrum appeared to be the primary pain generators of the hip joint, given their higher density of nociceptors and mechanoreceptors. So we represented on this figure the anatomic regions supplied by nerves which simultaneously innervated the hip capsule. The richly innervated areas of the anterior and posterior hip capsule could sometimes elude providers who may be focused on areas of referred pain around the hip. This was a visual representation of our concepts of local referred pain. We supported that the resulting frequency map of articular branches and sensory receptors of the capsulo-ligamentous structures of the joints could provide an anatomic basis to explain patients' symptomatology and could lead to improved diagnostic ability for surgeons. It may be possible to hone in on a patient's specific pain generator and focus a treatment plan accordingly. And we published over 20 papers about joint innervation, and the 3 literature reviews have been read several thousand times. Especially the most recent paper about the hip joint. Why is there this growing interest about joint innervation? We thought that the resulting frequency map of articular branches and sensory receptors of the capsulo-liga-mentis structures of the joints provided an anatomical basis with which to propose targeted denervation on pain generator and focused procedures accordingly. All these theories remained highly speculative. But for the hip joint, the anatomical study on hip innervation has made it possible to propose a new regional anesthesia technique called pericapsular nerve group block, which targets the anterior capsule of the hip by blocking these nerves. This PENG block permitted to reduce pain after total hip arthroplasties while sparing motor function. This technique involved the deposition of the local anesthetic in the fascial plane between the psoas muscle and the superior pubic ramus. This is an interfascial plane block, aiming to block articular branches supplied by femoral obturator and accessory obturator nerves, and is now a regional anesthetic technique as an alternative to other regional nerve blocks, such as femoral nerve block or an iliac fascia nerve block. With the current understanding of the innervation of hip joint, Peng and his team showed that the selective chemical denervation of the articular branches of femoral and obturator nerves could be a safe and effective measure to handle the pain-related and rehabilitation-related challenges as a result of inoperable hip fracture. Other authors also suggested that pulsed radiofrequency of the articular branches during Peng block provided prolonged pain relief in chronic hip pain due to osteoarthritis. And same works have been done for the shoulder. The frequency map of the articular branches supplying the glenohumeral and acromioclavicular joints, as well as their relationship to bony and soft tissue landmarks, provided an anatomical foundation to develop novel shoulder denervation and perioperative pain management protocols. And the joint denervation has emerged as a new technique, but the literature on shoulder neural ablation procedure was largely limited to pulsed radiofrequency due to the concern of motor impairment, and the current evidence does not suggest analgesic or functional benefit. Finally, high-quality anatomical dissections, large-scale registries, clinical studies evaluating different imaging techniques, and controlled comparative effectiveness trials, especially for ablative radiofrequencies, are required to confirm our speculative theories and to better identify likely treatment responders, and thus to shed light on the efficacy and effectiveness of this new way to treat the joint pain. And so, to conclude, the sensory innervation of the joints is still the dark side of the pain. Detailed knowledge of the innervation of these joints are important for planning and optimizing perioperative analgesia and interventional pain procedures. And of course, further studies are needed to confirm our speculative theories, the common innervation pattern, and the local referred pain with the nerve bridges. Today, these concepts are more questions than answers. But as said Sir Bragg, the important thing in science is not so much to obtain news facts as to discover new ways of thinking them.